All right. Well, I think we'll get started. Hopefully, everybody who is online can see the screen behind me, which is kind of the PowerPoint that we'll go through, as well as hear me. So hopefully, all those things come up fine. We'll do, obviously, kind of this in-person and digital dual presentation, if you will. So please let me know if you have questions or things that you don't understand. We can certainly slow down and kind of make sure everyone's on the same page. You're good, Emma? Okay. So this webinar, this seminar, we're going to discuss hip pain. And as you can imagine, hip pain is a pretty general topic. So I'm going to try to narrow it down. As you will see, we'll narrow down our focus a little bit and talk about the different conditions affecting the hip, as well as potential treatments for hip pain and hip issues and hip pathologies. So again, my name is John Odom. I am sports medicine doctor here at Odom Health and Wellness. We also have Andrew Moran, who will be presenting as well. He's the head of our physical therapy department, if you will, and he'll present as well some of the rehab aspects of hip pain and hip pain treatment. This slide just, I don't know if you can read it really, if you're online. It's kind of hard for me to see on this on the computer screen, but hopefully you can see it. I'll read it as well, and you can take down the number if you want. But we have a phone that you can contact. So there's a couple ways to contact if you have questions or if you have other issues regarding the seminar and regarding questions that come up afterwards. You can obviously chat during the Zoom call, and we'll try to respond to some of those questions. And then we have a HIPAA-compliant phone at 952-208-0241 that you can also reach us on. We'll have Emma, who works here at the clinic, kind of help field questions and try to answer any sort of questions or concerns that you guys have. Rob Okerlund, who's not here, is our regenerative nurse specialist, and he also will be available to kind of help field calls too. So some of the resources available for you if you have questions. So we should start out like any kind of good ortho talk, starting with anatomy. A lot of times we fly through the anatomy, especially when you come see us as patients. Yeah, we kind of fly through the anatomy, and most people aren't familiar with these terms. So let's start with the anatomy, so we can kind of talk like terms and then go from there. Most of what we do and what we treat stems from the anatomy, and obviously pathology we see with anatomy. So let's start there. So let's review. We have a couple of models here. So again, hopefully you can see the models and kind of get a good idea. This is a cutaway of just the hip itself. And so you have the iliac crest, you have the femur, the neck and the head of the femur, and then you have it as it attaches to the pelvis, or the femoral acetabular joint, if you will. And so those are some basic terms and basic anatomy of the hip. We'll go into that a little bit deeper, but I wanted to start familiarize you with all those kind of terms that we just throw out so quickly. This is a kind of important starting point as well, and that is to look at the hip joint as it pertains to the pelvis and kind of the midsection of the body, if you will. And so I want to point out a few things and make a few points regarding this and regarding this anatomy. So as you can see, if you turn the pelvis around, you have the lumbar spine. So you have here L5, L4, lumbar segments, and then you go into the sacrum here, and then you have the iliac crest, so the posterior iliac crest on both sides here. And then slightly inside there, you have the SI joint. So where the sacrum and the iliac meet is the SI joint. And then from there, you have the coccyx or tailbone. And so that's posterior, looking at the back of the pelvis and back. And then if you, again, turn to the front, you can see here you have the pubic symphysis, so the pubic bone. Most of these structures you can kind of feel on your own body. So it gives you some orientation. It gives you kind of some idea of how this pelvis kind of looks. This obviously is a cutaway. You have all your kind of uterine, abdominal structures that kind of lie here. And that's the only reason why you're seeing that part of the lumbar spine, because all that's kind of taken away. Other things to kind of note, so coming in this direction on both sides, you have inguinal ligaments, which kind of a little bit demarcates the abdominal cavity from the pelvic cavity. So that kind of comes down here as well. And then here you have the ischial tuberosity, which is kind of your sits bone. So most of you guys who are sitting watching this are sitting on these bones right here. And again, your hip is right here, your hip joint. So the femur attaches to both these acetabulum. You can kind of see how your femur here attaches to the acetabulum there. But you can imagine legs coming down here. And then you can imagine all sorts of structures that are on the outside of the hip bone here. So a lot of your butt muscles attached there. You have bursas that attach there. You have IT bands that kind of run there. A lot of structures here. And so one of the points I wanted to make, not only with starting with anatomy so that we kind of know we're talking about the same things, because honestly, when I see patients and they say I have hip pain, they commonly will kind of point here and say I have hip pain here, and that can mean so many things, right? And that's why we're like very particular about trying to narrow down. So where exactly is that? And honestly, some people, it's hard, right? They say I feel it here, but I don't know if it's back here or I don't know if it's here. So it may be a difficult task to have the patient, try to localize very well. But obviously that's really important to what you're treating, because if you can identify the anatomy that's involved, you'll probably be better able to treat what's involved. And so trying to understand anatomy where the pain is being generated from is really, really important. And so I bring up this model and I go over the anatomy, not only to familiarize yourself with kind of the terms that we're talking about and kind of things that we just throw out there, where they're talking about an X-ray or MRI, but I also bring this up because I would tell you that in sports medicine, in orthopedics, this is probably one of the toughest areas to treat. And again, I go through this little exercise about the anatomies because you can tell from this brief discussion how many things converge, right? So I put this little picture up there of rivers and kind of confluence of rivers kind of coming together and that sort of thing. And that's kind of similar to the hip and the pelvis. There's so many things that come together there that trying to identify what's going on can be very difficult. Trying to identify what anatomy is going on can be very difficult. You will have patients that come with hip pain and they'll see somebody else and say, no, I think it's coming from the back. You'll see somebody who had back pain and then they get imaging or try to rule that out and say, no, it's coming from the hip, or it's coming from the adductor, episymphysis, the labrum, you name it. There's so many different opinions on the same patient. You're like, are we talking about the same person? And yes, you're talking about the same person, but this is the reason why that conversation or that discussion or that diagnostic kind of exercise can be so good. It's because there's so many things that kind of converge in the hip and the pelvis. So I want to take a little bit of time to just kind of go through that to let you kind of in on some of the insight when we start treating. So when I see a patient and I think about hip issues, I try to break it up because, again, it could be so daunting thinking about all the different things. But the thing I try to at least start with is trying to figure out, is the pain coming intra-articular versus extra-articular? When I say intra-articular, I mean coming specifically from within the hip joint. Extra meaning outside. So extra-articular is anything outside the hip joint. And when I think about intra-articular causes, there could be more. Obviously, there could be more. You can have infectious causes, you have other things, but the three main causes intra-articular that we see are these three listed here. So OA for osteoarthritis, or the same thing as degenerative arthritis, a labral tear, and then impingement. So what is a labral tear? A labrum is kind of a cartilaginous cup that sits inside the acetabulum. So if you see this cup here, it's a bony cup. Right, it provides kind of a bony restraint for the head of the femur to sit in, so it doesn't dislocate. It sits in that kind of bony prominence, articulates with that bony prominence, and allows you kind of a range of motion. There's a lot of coverage between the acetabulum and the head of the femur, unlike the shoulder, which doesn't have as much coverage. So inside that kind of bony ring is a rim of cartilage. that rim of cartilage that sits in there is what we call the labrum. So you kind of think of the labrum, I like to use this analogy as like a golf tee. So like a golf tee will support the ball, it doesn't grab a ball, but it gives the ball a room to support. The labrum inside the acetabulum is the same thing. It's a rim of support. And you can imagine if you have a problem with the labrum, it can give you pain, it can give you instability, it can give you kind of multiple issues. So interarticular, again, I think of three primary things that can be going on: arthritis, labral tear, and impingement. And what is impingement? Impingement, here's a good picture of it right here. There's kind of three main types of impingement. You can have cam impingement, where the neck of the femur is kind of deformed, if you will. It causes a change in the range of motion. The bony architecture is changed such that it affects the range of motion, and it can cause pain every time it kind of impacts or is impinged upon that location. So that's what we call a cam lesion or cam impingement. A pincer is more on the cup of the acetabulum, and when that changes, you have, again, what we call a pincer impingement. And then obviously you can have combined, you can have both cam and pincer, which can really be a problem. So three types of hip impingement, and sometimes we see that again. It's one of the things we think about with intra-articular issues. Extra-articular issues and diagnoses, again, we kind of covered this as we went through the anatomy, that you can just see all the different things that may be involved that you have to think about. So you have to think about adductors, sternal tears, IT band, trochanteric bursa, SI pelvis, low back, gynecological issues. You know, you may have an ovarian cyst that could be causing hip pain. You know, GI certainly have a hernia, inguinal hernia that can be causing hip. Pubic symphysis, you can have pubic symphysitis. You can have stress reactions, stress fractures of those structures as well. So those are just to name a few things that could be impacting you extra-articularly. Hip OA, we talk a lot around here about arthritis and what it is, degenerative arthritis or osteoarthritis. And so let's dive into that a little bit for definition's sake. Again, probably one of the top things we deal with, is probably not a day that goes by that we are not dealing with arthritis. And so it's a big topic for us. It's something that, again, that we see and treat every day. So both myself and Andrew will touch on this. But degenerative arthritis, again, is really kind of a combination of a couple things. One, it's a change in the synovial lining. So if you think about the joint space, it's covered with the kind of a pristine synovial lining when you're young. One way I like to think about that is that synovial lining is kind of like Teflon on your new pan. And, you know, Teflon on a new pan is awesome. You know, as soon as you get home, you can put the food on there and just slides across. So nice. But after a couple of years, you get a fork, you get a spatula on it, it causes nicks in the Teflon, and then it takes away the efficacy of it. Then all of a sudden, you're back to kind of using olive oil and butter and that sort of thing to cook your food. The Teflon is similar to the synovial lining. Synovial lining, when you're young, is smooth, provides a frictionless surface for range of motion, and allows you to kind of move and run and do everything that you want. As you age, that lining gets wear and tear. And as that lining gets wear and tear, you get nicks in it. And then with the nicks comes inflammation. So inflammation is a key and important part of arthritis. So not only do you have the cartilage bony changes because of wear and tear, you also have inflammation as a result. Those two things go together. You'll never be able to separate in arthritis those two things. They both go together. And honestly, sometimes one will be more of a factor than the other, but both of them will always be there. And the best example I have of that is that sometimes you get an x-ray, AP pelvis, so you're doing an x-ray of both hip joints. And the person is coming to you with right hip pain. And you look at the x-ray and you have to double check. You have to say, which hip hurts you? Because on the x-ray, they might have more bony loss actually on their, quote, asymptomatic side. On their left side, they might have actually more bony change. It may look even more worn and torn, maybe even look more like it has bone spurs and less range of motion. But they have actually symptoms more on the right side. And the difference is the inflammation component. Like they may have more degenerative changes or bony changes on the left side, but the inflammation is greater on the right, therefore more symptomatic. Which takes me to the next point. The question I get a lot with a lot of patients is, if this is truly kind of a degenerative process, meaning it's been going on for a while, why all of a sudden, like after that fall, or after that infection, or after this particular thing, why did I come with hip pain and I had no idea before I ever had arthritis? Now it just looks like I'm going to need a replacement tomorrow. So how did I go from this progressive thing to all of a sudden like it's done? And part of the answer for that is the inflammation component. Injury changes inflammation. It can make your inflammation go way up. It changes all the supporting structures as well around the joint. And so that's another important point. You have bony changes, you have inflammation, and then you have protective mechanisms that guard the joint. And so we talk about this a lot in clinic as, what are the shock absorbers, or what are the things that protect the joint? Mainly, it's kind of muscle development, muscle and ligament development around the joint. And when you have an injury, compromise that support structure. And so now it's kind of collapsing on each other. You're having a lot more pressure in that joint because the protective mechanisms are gone. It's like having a car with no shocks. Anything you go over, anything you feel on the road is all of a sudden a big jar to you because you've lost your shocks, you lost your protective mechanisms. So that's I think a good summary on hip OA. So what's the current treatment for hip arthritis? What do we typically use if you go to most orthopedic clinics and you have bad OA, and whether you're going to be recommended hip replacement or not, they're going to first recommend a cortisone injection. And so here we're pretty down on cortisone injections because we feel like they don't really do anything for the underlying cause or the underlying condition. They may temporarily give you some relief, and we don't know if that release is from the needling, from the lidocaine, or from what. But if you think about cortisone is used because it's a really potent anti-inflammatory. Well, this is degeneration, so this is not acute inflammation like you would get in the first 4 weeks of an injury. This is chronic, so this is more degeneration. So even when you look at the pathopharmacology of why we use cortisone, it doesn't even make sense from that. And then you look at experience. We know from experience, years and years, myself and many other physicians, that it only works for a little bit. Like it may temporarily work the first time, but it certainly doesn't work after 2, 3, or 4, or 5. So why does it stop working? If it's an anti-inflammatory, inflammation is still there. It's because the medicine isn't really treating the chronic degeneration. And so cortisone really doesn't make sense why we use it, but we keep using it. That's a whole nother talk. So I won't go into that. It's a little bit of soapbox for me, but I won't go into that. And then, especially in the hip joint, this is kind of an important point, especially in the hip joint, not only is cortisone not effective, but there are studies that show it actually can be detrimental. A VA study, again, our Minneapolis VA did this study, and they looked at cortisone injection within the hip of our veterans and their benefit, their result, and their side effects. And they found that there was a greater chance of complications, namely what we call avascular necrosis after cortisone injection. So they found that the risk is much greater than what you would see in normal people wear and tear for avascular necrosis. Avascular necrosis is actually relatively rare. You see it in people who are chronic prednisone patients, chronic steroid patients, or patients who've had traumatic injuries to their legs and to their joints. So it's relatively rare, but they show a statistical significance in the increase in the incidence of, again, avascular necrosis, which you can tell by this picture what it is. It's basically bone death, where you block the blood supply to that area of the bone because that section of the bone dies. That's the definition of avascular necrosis. On X-ray, instead of being kind of a rounded ball, it looks like a flat head, and that's the radiographic sign of the avascular necrosis. And so, not only is it not effective, but it actually is dangerous and detrimental. So, for that, many reasons, I really do not like using cortisone in the hip. So, we'll discuss other treatment options. We'll talk about some regenerative options. Obviously, physical therapy is cornerstone to therapy and treatment, but the cortisone is horrible. Takes us to our one of the main treatment options we want to discuss today, and that's regenerative medicine. So, again, you see a lot of these situations, and I have a lot of patients every day who come and just say, well, I'm too young for a hip replacement. I certainly don't want to have a revision in 10 or 15 years. I want to stay active, all these sorts of things. I am or I'm not maybe even a candidate, but I have quite a bit of pain. Yeah, there's enough arthritis causing me inflammation, causing me dysfunction. What can I do? This is where regenerative medicine is a beautiful option. It's kind of a nice way to practice medicine. So what is regenerative medicine? It's the science of repairing disease or damaged tissues or cells. And again, actually repairing. That's kind of one of the key things. Actually repairing and try to heal. Whereas the other treatments, cortisone, does not do anything to heal. It can be accomplished in a number of different ways. It is a really hot area in all of medicine. So there's not a specialty in medicine, whether you're talking about cancer, or you're talking about pulmonology or neurology or nephrology. There's not an area of medicine that's not currently looking at the role of stem cells, the role of regenerative medicine to help in those areas. For us, we only focus on the musculoskeletal aspects of it. And so that's our main specialty is looking at regenerative medicine as applies to musculoskeletal medicine. So these next couple slides, I'll just warn you, are very wordy. So it's like presentation 101 to not have a wordy slide, but I put it on there and I'm going to read it because I want to also emphasize the importance of terminology and the importance of being very specific and very direct and very succinct in what we're defining as regenerative medicine and these kind of treatments. And so because of that, I've made these next couple slides kind of wordy. So bear with me, but I think it's worth it to just get this kind of insight and this kind of knowledge about what we're talking about. So we all are familiar with the term inflammation. So I'll read this from this paper that I took this out of. It said, all right, we're back. Sorry. Didn't even look over my shoulder. Didn't realize the words of God. Thank you, Andrew. So, talking about regenerative medicine, this process of inflammation resolution. Here's what this one scientist said about it, which he said it well. I see. Simply stopping the inflammation is not enough to return tissue to its normal state. So we think about what are the ways that we stop inflammation? Ice, compression, elevation, NSAIDs maybe not. There's some research that shows maybe NSAIDs doesn't do it. So let me read on. Ruslan Mensah, a professor in immunobiology at Yale School of Medicine. And when he's talking about inflammation, he's not just talking about inflammation as it relates to orthopedic, arthritic type situation. He's talking about inflammation, results of all of medicine. You'll see that inflammation, as I kind of read these slides, inflammation affects every area of medicine that we deal with. We're just focusing on the musculoskeletal applications of that, but really all the areas of medicine, people are trying to figure out how to control inflammation, how do we get resolution. So I'll go on and read this. This approach ignores the other side of inflammation, that is resolution. Again, I said that term a couple of times, resolution. So that means the ability to not only have an inflammatory process, but then to get cleanup, to get improvement, to get healing. That's the resolution phase. Resolving inflammation is an active, highly choreographed process for rebuilding tissue and removing the dead bacteria and cells. When the process is disrupted, inflammatory diseases arise. And again, that's a general statement, but it refers to inflammatory diseases when we talk about Alzheimer's, diabetes, obesity, or osteoarthritis. Those are all inflammatory disease states. And the early 2000 researchers began to recognize the role of inflammatory conditions in as varied as Alzheimer's, cancer, diabetes, heart disease, prompting them to recast inflammation as a unifying explanation for a myriad of elements, including those we develop as we age. Yes, even aging itself and its associated pathology is driven by persistent inflammation. So even the process of what we think about aging is we get to know aging. Part of that whole process of what we call aging is this persistent inflammatory process. Until relatively recently, we believe that inflammation just stopped. So once inflammation happens, it stops. But this Molly Gilligan, internal medicine resident in Columbia, who studied this immune system and its impact on cancer, studied the products of inflammation. She says molecules that trigger it in dead cells and tissue are eventually metabolized and spontaneously dissipate on their own. That's what we thought. But the reality is more complicated. And recognizing that can have game-changing effects on how we treat a wide swath of diseases. So we thought you get this reaction, you have all these dead cells laying around, that's it. You just have these dead cells laying around. But she says it's way more complicated. You got to get the dead cells out of there. You got to get kind of new tissue, new cells. Well, the researcher that I quoted before has this analogy, and I really like this picture. He likens an infection to a broken pipe that has flooded an office with water. So imagine this whole office is just flooded with water, right? We can go and fix a pipe, and that might stop the water from streaming in, but doesn't restore the office to its previous functional state. Similarly, inflammation has a cleanup phase known as resolution, and it proceeds in a series of highly coordinated steps. So that's what we're talking about as far as regenerative medicine and how it works in osteoarthritis. You get inflammation as a result of wear and tear, and it's like this office is flooded. Well, we can stop the inflammation. You know, we can do compression, that sort of thing, stop it from kind of getting worse. But the office is still a mess. Your basement is still flooded. How do you get back to normal function? How do you get back to living? That sort of thing. It's got to be the resolution phase. How do you stimulate the cells that go in and clean up all that kind of junk? It's the resolution phase as stimulated by regenerative cells. So regenerative medicine, we talk about a few different ways, and my time is kind of getting away, just kind of introducing this, but I will, because of the sake of time, I'll kind of hurry a little bit more through these slides so that Andrew has some time to talk as well. When we talk about regenerative medicine in here, we talk about basically three different players. We talk about prolotherapy, PRP, and stem cells, and I'll define what I mean by that because I say that word very loosely. Prolo is just a process of using dextrose as a biologic to create kind of this healing response. PRP is a process of taking a patient's whole blood, spinning it down to just a super high concentration of platelets. We found that to be effective, you have to have at least 1 billion platelets per milliliter. And so that means you have to have a good concentrating system that really concentrates the platelets well in order for it to be clinically effective. We have a great system, this MSite system, we have great processors, and so we're able to get you a very high concentration of platelets. Platelets work, again, to cause and help that resolution phase that we just talked about. Stem cell is another cell, so you have platelets that help with resolution and cleanup. You also have stem cells that kind of help with that. When I say stem cell, again, I say that term loosely because what we're talking about, maybe more specifically, is what we call mesenchymal stem cell. And what they are, this definition here, they're a multipotent cell found in bone marrow that are important for making and repairing skeletal tissue, such as cartilage, bone, and fat, found again in bone marrow. With age and disease, these MSCs, or mesenchymal stem cells, convert into lipid accumulating fat cells. Another name, so I heard a lecture a couple of years ago about the guy who actually coined this phrase, mesenchymal stem cell, and he thought a better name for it, we should go on from here on out in the literature, calling it messenger signaling cell. And so what he meant by that is that the cell does have an effect to be able to kind of convert into other cells, but maybe more importantly, it's maybe greater function is that it signals. It calls other cells to the area and it kind of orchestrates this, again, myriad of repair. So that's probably a better name, is messenger signal cell. For our terms, we'll just continue to call it MSCs. One of the things that MSCs do is this, again, paracrine effect, where they stimulate other cells to, again, repair and turn over. This is kind of an example of a paracrine cell. We talked a little bit about stem cell here. Here's a good picture to kind of help you keep in mind what MSCs are doing. They're conducting. So like I said, they're orchestrating all these kind of cells come there. They're having kind of macrophages clean up stuff. They're having interleukin growth factors come, growth factors themselves, cytokines. They're having all these kind of, cell soup come to the area. That's all being orchestrated by MSCs. Platelets do a lot of the same work. They work as construction workers, so they go in and they kind of build scaffolding for new tissue growth. And then they're firefighters. As we said, they have really important ability to reduce inflammation. When we do MSC extraction or harvest, we take them from patients in 2 ways: from their bone marrow and iliac crest, or lipoaspirates from the adipose, so the love handles, bone marrow organs. We have these stem cells within our own bone marrow. We talked about these clinical applications. Again, the main one we're going to focus on is arthritis. But as we went back to originally in our pelvis, there's much more structures kind of involved in just the joint. So there's all the muscles that act on the joint and all the tendinopathies that result with muscle dysfunction. There's, bursal issues, there's back and low back issues that kind of go into that. And so typically we treat multiple structures in multiple areas because there's usually multiple things kind of affecting pain function. All respond to, again, these regenerative cells. So it's about the tendon that. There are some contraindications, and procedurally, this is what we do. This is what we've specialized in. So we have a highly coordinated, specialized team to deal with this. As you go through this process and you consider this, we bring you through do's and don'ts, what to expect, day of procedure, how to take care of it afterwards. It's really important afterwards to make sure that you have rest, you have physical therapy, you have good nutrition. So again, I'm way over my time. I think I'm 15 minutes over my time, so I don't want to get Andrew mad. I'll let him finish. Take us through.
Thanks, Dr. Odom. Well, I feel like we all have a PhD level education on regenerative medicine now, so we can probably call it a day there. But no, I did want to touch on implications and get a little bit more practical to build off of Dr. Odom's good big picture that he kind of painted. And so what we found here at the clinic is that it's so imperative to have PT, physical therapy, intertwined with your regenerative medicine treatment. And so really what we've discovered is that there's a handful of factors that play into optimizing your injection as opposed to getting the injection done and then sort of hoping and praying, right, that this kind of materializes into long-term results. We see a lot of people who come even out of state that come get it done and they get very impressive results over time. However, in the short term, that's really where we can use that opportunity as someone comes in and gets Prolo, PRP, or mesenchymal stem cell injection, and we can kind of work with their anatomy, help improve their biomechanics, and optimize their situation so that not only are they going to get a better result, but the likelihood of any kind of relapse or a tissue to sort of be more subjected to wear and tear over time is going to go down. So that's kind of what I want to touch on a little bit of how we do things when we blend PT with regenerative medicine. And so essentially the goals that we're trying to create and accomplish here are protecting the environment of the injection through improving our biomechanics, right? So if someone comes in and they want to get back into exercising and they're trying to figure out how can I get back to doing like some squats, if I have some stuff I have to pick up off the ground, if I have some grandkids or kids, and that's a troublesome thing for me to have to be able to do. But of course, we want to go through what does it mean to squat correctly so that we can put you in a position to succeed, right? As opposed to going through the trouble and the hassle and investing time, energy, resources into this injection. We're all excited about it, and then we don't improve that squat form, that technique. Of course, we want to make sure to do our due diligence there. So improving biomechanics is key. Creating joint mobility. So Dr. Odom spent a lot of time talking about joint space and the inflammation aspect of it. So if we can go in from a PT standpoint to come alongside an injection and make sure that you have the most possible range of motion that you have in the joint, it kind of plays onto that effect that Dr. Odom was discussing, where when you have a pool of swelling that's in a joint, if you can improve the motility of that tissue in the capsule, you can really allow that swelling effects to have less of a painful response in your case. So first and foremost, biomechanics, creating mobility, and then that creates the space to improve this notion of fostering musculoskeletal stability, which is what Dr. Odom was talking about as well. There is a stage where we have to get the muscles and tendons stronger, and that comes through work and putting in the work, rolling up your sleeves a little bit, and that's where we'll kind of educate and kind of be alongside patients, showing them the right exercises to do and the right timing at which to return to activity, which we'll talk about here. So quick overview, this is dovetailing with what Dr. Odom was talking about, how everybody and every body heals, right? there's these phases of inflammation that have to play out in the healing process. And so this initial response when someone comes in and gets an injection, people want to know what's the after look like. So this is what I'll talk about with you when you come in for that first follow-up visit after your PRP, prolo-PRP or stem cell injection, right? There's this phase of where you get stirred up a little bit, right? And we kind of like to see that. It tells us that we almost hit the spot, for lack of a better term. And you kind of want to see a spike in symptoms because we know that inflammation process is taking place, right? And that usually ranges from anywhere from 0 right after you have the injection done to 3, maybe 4 days. And by that span of time, you'll see this effect of the inflammation starts to calm down a little bit, right? From there, we start to get into this proliferation phase where new tissue is going to start to be laid down, depending on the tissue that's injected. If we're talking about ligament, tendon, joint space, labrum, or even down into the muscle region. And then the long term is this remodeling phase. That's kind of like what Dr. Odom was talking about with the flood analogy, right? Someone has to go around and put things back in right places. Remodeling is when we can really load tissue and it's more resistant to having a similar setback that it's had in the past. So it's kind of this initial phase is 3 to 4 days acute, stretches into 3 days to 3 weeks. And then beyond that, we see this kind of 3 to 4 week mark for the rest of kind of an ongoing process for years down the road is kind of that long-term remodeling phase. And so what that kind of plays out to is how we sort of use that natural time frame of healing from a PT standpoint to come alongside the injection that's taken place in the normal injury process of healing. And we know how we can fine tune and do what we call the right load at the right time. So early on, when we're in the inflammatory phase, someone presents with some pain. They're going to get this injection done. They're all excited about it. They're like, you know what? I'm excited to do this. It's a little bit different than maybe just going and getting the surgery. And so we'll see them on the before end of an injection and we say, great, so glad you're coming in now. Let's get your baseline measurements. And here's what you can do right after the injection. And that's where we talk about increasing mobility. So giving people exercises, very gentle ones that'll help foster and come alongside that inflammation process to help patient achieve inflammation balance. Proliferation phase, that's where we talk about starting to insert some stability. So getting muscles to fire, getting some good activation in tissues that have probably gone a bit dormant or silent, because we know swelling has a little bit of a resistant effect for musculoskeletal use. Sort of like when everyone likes to talk about Adrian Peterson's ACL recovery whenever they come in. I want to get back as quickly as Adrian Peterson did, right? But even you take a guy like that, who is probably one of the strongest people that you ever encounter, I can guarantee you right after that, when his knee was swelled up post-surgically, his quad function went way down and he could probably barely walk, right? And it's not because his strength went away overnight. It's just because the swelling that takes place inhibits function of muscle. So same thing here. We're trying to gradually insert stability and get the muscles to fire again in that proliferation phase. Remodeling, that's where we talk about returning to full activity. And for us, we're very focused on outcomes. We like to see images. Of course, Dr. Odom talked about the role of imaging and its limitations too. We like objective variables, but at the end of the day, our goals are your goals. So if you want to get back to doing that local 5K or getting back to that group exercise class or going on a walk with your friends, like that's how we're ultimately going to measure this being successful. So that return to activity is that long term. And then healing based on the injection type that you do, right? That's where it can be nice to sort of ballpark what you can expect in terms of long-term potentiation of your injection that you choose. Dr. Odom talked about prolotherapy, which is a dextrose solution that stirs up healing, right? That's more of a nimble, easier entry point into regenerative medicine. On my end and on our PT staffs, and we'll see that people normally get a turnaround within 4 days to a couple weeks. You kind of know where you're going to be at from a prolotherapy standpoint. So it's nice to sort of get an initial response, see if you respond well to regenerative medicine as a whole, without having to kind of go through that full spectrum of care if it's not needed and it's determined that you wouldn't need it at this point. PRP is kind of that hybrid option, which we like a lot, where you'll get a really strong response and you typically know how you're going to respond within about 5, call it to 8 weeks. There's always a bit of variance with every kind of every person, every injury is a little bit different, but you kind of will kind of ramp down and then build back up. And by about that 6 or so week mark, you're pretty much back at it to doing full activity again. And you should be very confident in knowing that you're getting some good results by that point. And then BMAC I put on here, which is another term, a bone marrow aspirate concentrate. That's another term for mesenchymal stem cell injection. And so that's where we look at gauging it from a little bit different lens. And this is where we want to see those breadcrumbs of improvements. And we definitely see it and liken it to a response that a PRP injection might give functionally, where you'll have this proliferation phase after the acute phase, where you do feel better as the weeks go on. By about 3 to 4 weeks, you're feeling encouraged that you chose to do it. And at about 8 weeks, we're starting to test you. The cool part about going with the mesenchymal stem cell injection option is you'll continue to see results and benefits for months later on down the road. So this is where we'll get the phone call from a patient 4 to 6 months later after they had their injection. They're saying, you know what, I'm feeling pretty good. I think I'm ready to try this on my own. We feel pretty confident in where they're at. We'll get a phone call 2 or 3 months later and say, hey, I feel amazing, like head and shoulders even above where I was before. And that's the stuff we get really excited about, because we feel like we help to assist them, put them in a good position to succeed, and then they continue to see your longer term results with the stem cell injection, which is encouraging too. So a little snapshot of what you can expect, like time frame wise after an injection. And then to bring it full circle there, Dr. Odom touched on this too, different tissue types are going to respond at different iterations and different time frames too, right? And this is not a hard and fast, like this isn't quite gospel, but we see these trends in terms of anecdotally and in the literature as well. Ligament is going to take a little bit longer to heal than labrum, then tendon, then joint, then muscle. So you'll kind of see the more vascularized the tissue, the quicker it's going to turn over, and you'll see results in generalities, right? We'll see people that come in and kind of buck that system a little bit, where we kind of will say, yeah, we think this is going to take a little while, hang in there, and they'll get a much quicker response than we would anticipate, which obviously we celebrate that and we're excited about that. And then you'll see it on the flip side, where sometimes it is a little bit longer than we anticipate. The results come, but a little bit more delayed. In generalities, again, ligament, labrum, tendon, joint, muscle. That's a good kind of framework to conceptualize. And overall, to kind of bring it full circle, I like this analogy of capacity. And that's a good term for how we talk about progress in physical therapy, because really that's what we're after. And this slide, it's I'll read it to you here, what it kind of gets at. It's this analogy of a cup. And the cup kind of is your capacity, or how much you can withstand in your output. And within this cup, we have a lot of variables that can contribute to how a person might feel. And within that, we talk about stress, we talk about sleep, nutrition, strength. Dr. Odom talked about inflammation, and ultimately pain. And so we're faced with all these factors where someone comes in and says, my hip hurts. And that's where we take the time with a longer maybe appointment than some clinics, what Dr. Odom was talking about again, right? We feel like we really got to get to know the patient and understand what's life like at this point. Is there some work stress going on? Do we have adequate sleep where we're able to get some recovery naturally? How's our diet looking? What is our baseline level of strength? And kind of comb through all those details with a fine-tooth comb, really, right? And once we know where we're at there, we feel like we're in a position to help you come along and understand what is the issue really here, right? Do we need to reduce the amount of variables that are going into the cup, or do we need to build a bigger cup? And that's where we kind of come into play, where there's 2 ways to go about this. What we're trying to do is build a bigger cup with our capacity, with our regenerative medicine, with our physical therapy, give you the ability to become more so that you can withstand more. And that's really the big picture view of what we're trying to accomplish here. Of course, we want to clean up all those variables that can contribute to hastening and encouraging symptoms to present, like sleep, inflammation, stress, all of those things. And ultimately, if there's weakness or pathology in play. But if we can build a bigger cup, that's what we're truly after. So we'll open up for questions in the chat at this point in time. If there's anything we can cover, we'd be happy to do so. We sure appreciate you guys taking the time out of your day to join with us online. And we'll definitely take the time to replay this and send it out just so that you guys have access to it. In terms of tangible next steps, right? Like what would that look like? Let's say maybe there's a couple things that might have hit home or stirred up some questions or further thoughts in your mind. We try to make that really easy to sort of carve out next steps so you can get yourself in a good position. What that would look like is simply calling in and saying, hey, I was on the webinar. I wanted to set up an appointment with Dr. Odom, right? And to see if I'm a candidate for this. So that's the easiest way to sort of take that next step and to explore and get the right diagnostics in play for you. Otherwise, if you have more questions about a specific topic, we're here, we're available, we're a resource for you and our community. whether it's for you, for a friend, for a loved one, whoever that might be. So definitely consider us your advocate as we come alongside you and help you guys out. So we'll take a peek at the chat here, and if there's anything coming to mind, I'm just going to jump right on here and see. Otherwise, we'll kind of wrap it up after that. Good to go. Okay. Well, thanks so much for joining, guys. Have a great rest of your night, and looking forward to have you on the next one.